My name is Elena Sokova. I'm the Executive Director of the Vienna Center for Disarmament and Non-Proliferation. And it's my greatest pleasure to welcome you all today to a webinar which is focused on COVID-19. What else is we're all discussing these days? We're all affected and all looking forward when this nightmare ends. But I thought it would be really interesting to hear not only about the pandemic itself, but about overall implications of this pandemic on global health and global health security in the first place. And I'm so delighted that today we have Dr. Richard Pilch, who is currently the Director of Chemical and Biological Non-Proliferation Program at the James Martin Center for Non-Proliferation Studies in Monterey. He's a physician by training, but this is not his first time with CNS in Monterey. And I'm so glad that I had a chance to work with Rich when he was a postdoctoral fellow at CNS in 2002. But since that, he has done a lot of interesting things related to global health, health security and national security issues. He's a physician by training and focused quite a bit on these global health issues since 9/11 and follow anthrax threat letters attack, and then spent many decades both doing implementation work related to addressing biological warfare, bioterrorism, public health emergency issues, worked with the former Soviet Union legacy offensive program, many of the training programs on non-proliferation, bioethics, and global health security, and implementing traditional threat reduction programs, including on pandemic response. Dr. Pilch served on over 30 technical panels and advisory boards, and authored more than 60 technical publications and white papers. And he also co-edited the definitive Encyclopedia of Bioterrorism Defense with his longtime mentor and a former dear CNS colleague, Dr. Ray Zelinskis, unfortunately, who passed away several years ago. But I'm so delighted to have you today with us, Rich, and I'm looking forward to learn myself from you, and I'm sure the audience is eager to hear what you have to say as well. Thank you. Please
great. Thank you. Thanks, Elena, and thank you, everyone. I'm very honored to be here. I'm going to go ahead and share my screen.
While you're doing it, maybe I'll just say a few words for those who have joined us. For your questions, please use Q&A function. For those who are watching us on YouTube, please send your questions to events@vcdnp.org. And if the chat function should only be used for if you have some technical questions. With that short technical note, Rich, please take it away.
Great. So in our time today, what I'd like to do is, let me just get my slides advancing here. So first, just talk a little bit about where we are in the pandemic, and then go rather briskly through sort of the key knowns and unknowns that we have about COVID-19. And then get into the origin investigation a little bit, because that's, I think, on everyone's mind. And then finally wrap up with a discussion of security implications. My goal will be to finish relatively quickly, so not drilling too deeply into any one of these topics, which can go on forever, But if you have questions about an individual topic, please do ask it, and we can go as deep as anyone wants to. Elena will also share my contact information with all of you so that if you have any questions, I'm more than willing to try to help anyone answer anything after the event. So here's a global map of where we are as of yesterday on, and this is from the WHO website. And where we are right now is over 100 million cases and over 2 million deaths. So that roughly translates to a 2% case fatality rate. For comparison, the general influenza case fatality rate is about 0.1%. So of the cases that we know, and these are, again, diagnosed and reported cases, we're seeing a 20% or a 200 times increase from 0.1. Well, let's do the math here. Yeah, the 20-time increase from 0.1 case fatality rate to 2% case fatality rate. How that equates in America, typically we see about 50,000 deaths from influenza a year, and we have just crossed over 500,000 deaths for COVID-19 in our first year. So I think my point with this opening slide is the comparison with influenza ends on this slide. We just can't really talk about the two in the same way because they're very, very different as far as the impact they've had on our populations. Globally, so on this slide, what we'll just talk about is global trends. And the upper right graphic is from the WHO report that they release every 2 weeks. So this data is a little bit behind the data we had on the last slide. But what this graphic is showing you is if you look at the case counts listed on the left-hand side of the graphic, these are daily case counts that we're seeing by region in the world. And what you're seeing is that over the past few weeks, your daily case counts have been going rapidly down. The black line is showing deaths. And so the deaths trails the case counts slightly, but deaths are now in decline too. So we're in a positive position now with the outbreak. And there's reason to be confident that that will continue with the rollout of vaccines. At the same time, we are seeing variants of the COVID-19 causing virus emerge, and these variants may or may not have a substantial impact on our current outlook. And so we'll talk a little bit about those moving forward. So key determinants for where we are going to end up. The first one is, can we get people to do or continue to do the non-pharmaceutical interventions that we know work? Okay, so we know masks work. We know distancing works. We know limiting indoor gatherings work. Can we get people to continue to do that? Second, can we continue our standard clinical medicine and public health practice? And that's essentially when you detect a case, you isolate and treat it. Then you do contact tracing for any of the contacts from that case, and you quarantine them and watch them for symptoms. There are reasons why that approach doesn't work very well with COVID-19, and we'll go into that in the next slide. But that is the bread and butter public health response to any outbreak. And we need to continue to do that and have the capacity to do that, which of course has been one of the major limitations with COVID-19. Having the testing capacity, having the contact tracing capacity, and frankly, having the healthcare capacity in our intensive care units and elsewhere to manage the caseload. The other two sort of big drivers here are first of all, when people get sick and recover, whether we detect them or not, how protected are they? And how long does that protection last? And then lastly, what will the impact of vaccines be? Will we get them out quickly enough? Will they be protective enough, and for how long? And we'll sort of go into all those points as we move forward here. So we have 3 or 4 slides on key knowns, and I'll go through them point by point quickly, but we can dive back into these as much as you want in the Q&A. So first key known, the virus is mainly transmitted by respiratory droplets. So we do still consider surface contamination. We still recommend washing hands, decontaminating surfaces, but the vast majority of transmission appears to come from person to person respiratory spread. So what that means is that these non-pharmaceutical interventions that I've mentioned are very, very effective, because if you can put a barrier or a distance between person-to-person spread, you can limit person-to-person spread. The virus needs to be inside a person and a human cell to survive and propagate. So by creating that barrier, you are actually interrupting the chain of transmission and the ability of the virus to grow and spread. If we were to talk about, and another real reason why these non-pharmaceutical interventions are important is the next bullet, and where I want to sort of emphasize and bring out with the red font here is when we talk about why COVID-19 is so different from everything else we've seen and sort of really caught us unable to respond to it. It's because the vast majority of transmission occurs before there are symptoms. Most of the time, or more of the time, that means that it basically people who are infected with the virus start shedding the virus before they show symptoms. And that's different from, say, the original SARS virus in 2002, 2003, where viral shedding would increase as a person got more and more sick. And so you're able to detect a case and isolate the person before the person is shedding a lot of virus, and you're able to stamp off an outbreak. In this case, we see before a person develops symptoms, he or she is already spreading the virus. Now, in some cases, the person will never develop symptoms. And in fact, a lot of cases, if you look at the number there, of the 60% that are transmitting pre-symptoms, 25% may never develop symptoms. When symptoms do come, the most common symptom is cough. The three most common symptoms are cough, fever, and shortness of breath. And they're generally seen in at least one of those three in cases that we identify. Anecdotally, in other words, in my personal experience from the people I know that have had the virus, they have all noticed it and gone and gotten tested because of the loss of sense of smell. So I think that's another one that is unique to this virus and something that people should pay attention to. Of the people that do have symptoms, about 80% are generally mild. So where do we see the bad cases? The bad cases typically come in the elderly, and that's sort of stratified from age 65 and up is a concern, age 75 and up is a much greater concern, and then above 80 is if they get the virus, they're in a much higher risk of severe illness or death. And in addition to the elderly, certain underlying health conditions. So the underlying health conditions we know of that increase the risk of severe illness and death are cancer, chronic kidney disease, chronic lung disease, certain chronic heart conditions, transplant recipients, sickle cell anemia, and then a couple of more common things, at least in America, obesity and type 2 diabetes. There are other underlying conditions that we are concerned about, things like asthma, but those are the ones that we've actually got fairly good data suggesting that they are at increased risk. In America, we've seen that 80% of the deaths occur in the age 65 and up population. In America, we also have seen that minorities are at increased risk of infection, hospitalization, and death. That's a long conversation to try to get at why that is. But in general, I think we can say that it's because there's an increased risk of exposure for many reasons, including being out in the workforce, doing the jobs that need to be done to keep our society going, living in inner cities, living in intergenerational homes, things that will increase exposure. All of those things increase exposure. And then once being exposed and infected, there are increased underlying health conditions that can potentially lead to more severe illness and death. and major discussions in America going on right now about why are there increased underlying health conditions? What is the equitable healthcare approach moving forward to make sure that that is not the case moving forward? And then sort of last point here is now that we've had a year in on COVID-19, we're starting to learn a little bit about long-term consequences. And this is another area where COVID is very different from influenza. COVID, we are seeing a legitimate long-term consequences from people that are infected, and they're impacting their ability to live normal lives. So another question about how long-term recovery will be from this virus. Okay, so vaccines. I'm not going to go in detail into vaccine mechanisms, but I'm happy to talk about them. I also won't go into detail into how the effectiveness is calculated, but I'm happy to talk about that too. There's sort of important implications about how effectiveness is calculated that lead to the question of whether vaccines actually reduce transmission or whether they are preventing severe disease and death, which we know they do, but potentially allowing transmission to continue, and that's an area of intense study right now. What we do know for sure about these vaccines are, one, they're safe, and two, they are effective at reducing severe illness and death against the current variants. Okay, so as the virus spreads, natural changes in the virus genetic code happens. Some of those changes offer a selective advantage, and those changes that offer a selective advantage tend to outgrow the earlier versions of the virus. So when we talk about virus evolution, it's really a random thing, but then the strains that are more fit to survive will be the ones that grow faster and sort of take over the spread. And as we're seeing some of these new strains emerge, we are concerned that some of the changes are occurring in the areas where our vaccines recognize and could potentially reduce their effectiveness. So the vaccines are all built on recognizing, or the ones I'm going to talk about here are all built on recognizing the coronavirus's S protein, which is called the spike protein. It's the reason coronaviruses are called coronaviruses. If you think about them, they're like these little balls with a bunch of little spikes sticking off of them, and those are the S proteins. And that S protein is what attaches to a receptor in the respiratory tract that enables the virus to get into respiratory cells and do its damage. So operationally, if we look at the types of vaccines that are out there right now, we've got two initial vaccines in the United States that are approved. They're called mRNA vaccines. They are very effective, very safe. They have a major downside, which is that they require deep cold storage. In other words, a refrigerator temperature is maybe 4 degrees Celsius. A freezer is maybe negative 18 degrees Celsius. These two vaccines require negative 80 degrees Celsius or close to it. So that creates what we call a cold chain problem. Very, very difficult to get the vaccine out to people, particularly in remote areas, without having the vaccine get ruined, right? Because if we can't keep it cold, it won't be effective. And we also don't really have a good way of testing whether it maintains its effectiveness in that situation. So good vaccines being used widely in America right now, but the cold chain concern is a big issue. Tomorrow in America, we will do an analysis of a third vaccine. It's a different mechanism. It's called an adenovirus vaccine. It's a little bit less effective at reducing overall symptoms, but it is still very effective at reducing severe symptoms. And I expect it will probably be approved for use in America. That vaccine is similar to a fourth vaccine that is already approved in the UK called the AstraZeneca adenovirus vaccine. And those two, the advantage of those is because they're not this, what we call mRNA vaccine, which is the one that requires the deep cold. These only require really being kept in a refrigerator. So they're much more stable and they're able to be delivered much more easily. So I think as we roll out our global vaccination campaign, we will see that these two vaccines, and in particular the AstraZeneca vaccine, will be leading the way because they have this increased usability, stability. And in fact, just yesterday, the WHO's COVAX program, which is its international vaccination program, shipped its first lots of the AstraZeneca vaccine. So that's what they're going on with. There are plenty of other vaccines out there. There's a Russian vaccine, which has tested very, very well. There are two vaccines that come from China. The first one hasn't tested great, or it's been intermittent effectiveness. The second one we're still learning about. There's a vaccine from India. So these are just a few. There's actually over 100 vaccines in the pipeline. How are these vaccines administered on the global level? Well, the plan is to have really a two-phased first phase and then a second phase. And the two-phase first phase is get enough to everyone who participates in this WHO vaccination plan so that they can vaccinate their frontline healthcare workers, because those are the people at greatest risk of exposure. And so those are the people that need to be protected the most, particularly because they are the ones continuing to manage the outbreak or the pandemic and also have interface with high-risk people of severe disease. Part 2 of phase 1 is then to vaccinate those people with the high risk for severe disease. That will get to an estimated 3% of any individual country's population. In phase 2, additional vaccine will be given to boost up to in part 2 of phase 1, we'll go from 3% to up to 20% of the population. Then in phase 2, there's effectively a triage approach where whatever vaccine we have left, we're going to give it to whoever needs it the most, which in my opinion is what we should be doing all along. But so if you look at those numbers, I mean, the maximum we're going to get to any one country through this COVAX facility is really not much. We're not vaccinating entire populations. We were worried about those at most risk of exposure and those at most risk of severe disease. We have a number of treatments available to us at this point. Remdesivir is an antiviral agent, which basically it interrupts the ability of the virus to replicate or make copies of itself inside the cell. We then have 3 approaches to basically provide antibodies to a person without either getting infected and recovering or getting a vaccine that develops antibodies. So these 3 approaches are what's called the Regeneron antibody cocktail. There's a new second antibody cocktail, and then early convalescent plasma, which is basically just taking survivor plasma and taking the antibodies from that and giving them to people. Those are all considered good at reducing progression to severe COVID-19. But as far as data that actually say, we're pretty sure this reduces mortality specifically, we're really looking at more basic anti-inflammatory agents like dexamethasone and others. You know, we're giving oxygen and we're giving supportive care. We're doing the things we have done since I learned medicine 25 years ago. Nothing really new as far as preventing death. So key unknowns. Well, we sort of started with this, but let's just go back through them quickly. So the big one is the emerging variants and how much that's going to change disease transmission and our ability to mitigate it through vaccines and through you know, acquired immunity after infection. We really need to know how much acquired immunity we have, both from the cases we know about and the cases we don't. We have to know whether that's protective, and we have to know for how long. We have to know the impact of our vaccines. How quickly can we get them out? Will it be protective? Will it reduce transmission? And what is the duration of protection? And then how will that vaccine landscape change as first emerging variants may draw into question the efficacy of our vaccines, and second, we get new vaccines coming through the pipeline available for distribution. So the key variants, and I use some colloquial terms here that are not meant at all to implicate any countries. They're just how people can remember them. I personally find sort of any variant has multiple different names, and it gets confusing to me. So I typically think of them in terms of the UK variant, the South Africa variant, and the Brazil variant, but they have multiple official names, which are here. But what are these variants? So these variants are, we already mentioned, a virus needs to be in a cell to make copies of itself. When it does that, it makes mistakes. And those mistakes for this virus, there's a proofreading mechanism that tries to fix them, but some get through. And those that provide a selective advantage persist and outgrow the others, and those that don't provide a selective advantage go away. So one change in that process has led to a different amino acid being made by the RNA, by the template of the virus. And that change is what we call the N501Y spike protein change. What that means, it's a confusing number. All it means is that at position 501 in this long amino acid chain that the virus is coding for to make its spike protein, which again is the thing sticking out of the virus that binds our receptor, one amino acid, N, which was asparagine, changes to Y, which is now tyrosine. And that change, that slightly different amino acid, makes it better at binding, and it makes it spread better. So up to 50% better. So if you hear people talking about, man, we have to rush with our vaccinations now, is to try to get out in front of this now increasingly rapidly spreading variant of the virus, which is outgrowing the other variants of the virus that we've had up until this point. Our vaccines are still, we believe, very effective against this particular change. Now, when we talk about the South Africa variant, it has that same change, but it has a second change at amino acid position 484, where one amino acid is now changed with another one. And that's the one that's concerning to us, because that one looks like it changes the same spike protein, but in a way that reduces the ability of our vaccines to recognize it. And our vaccines, again, target the spike protein. So if our vaccines don't recognize it as well, our vaccines are less effective. It also could mean that the immunity we get from being infected with an earlier strain may not be as effective. It could also mean that our antibody cocktails that we're giving are not as effective. So there's a significant concern about the impact of this particular E484K change that we're investigating very heavily right now. In the Brazil variant, it's newer than the other two. There's less information, but it also has both of these changes. So again, a concern not only for increased spread, but also for what we would call immune escape, the ability for our vaccines and our adapted immunity post-infection to not be as effective. Okay. Well, that was 30 minutes to get us to the good stuff. So we won't talk too long about this, but let's just talk sort of briefly, and then we'll go into the Q&A. So first off, up top of this slide, I put sort of a publication that my organization has put out on a methodology for investigating outbreaks, in case it's of interest to anyone. But as I think most of you know, we still don't know where this virus came from. That's the bottom line. An investigation began last month, earlier this month, I guess is better term, because people were held in quarantine before they started the investigation. And there was an international investigation team from the WHO that went to China to try to understand better the origins of the virus. They went specifically looking at 4 hypotheses. Those 4 hypotheses are that the virus came from bats, went through another animal into humans, and the precedent for that is the SARS 2002-2003 outbreak. That's how that outbreak happened. The second hypothesis is maybe the virus went straight from bats to humans. The third, which was one that I was surprised about, frankly, was, did it potentially travel on frozen food? And the fourth is, did it potentially escape from a laboratory? And just to be very, very clear, escape from a laboratory does not mean escape from a laboratory from a weapons perspective. It means legitimate research being done in a laboratory to investigate a virus and then an accident. And it happens all the time. It happened in 2004 in China with the original SARS virus, where someone working with the virus got infected and then took it home and infected close contacts. So it's not a hypothetical discussion. These are very real things that happen. Okay, so those were the 4 hypotheses that this investigation team was exploring. And they basically came away saying, we don't know. We need to do more investigation. So my approach to this is different. My approach to understanding the origin is we need to understand why, when we first learned of SARS-CoV-2, was it already very well adapted for human-to-human transmission? So let's talk a little bit about what that means from a structure of the virus perspective. The closest relative we know to SARS-CoV-2 virus is called RATG13. Now, what that means, it's just an acronym. It's RA means it's the name of a bat, Rhinophilus affinis. TG means Tongguan, which is a location where that bat was identified, and 13 is the year 2013. So we have a bat virus from Tongguan, China, collected in 2013 that is 96% close to SARS-CoV-2. And that's the closest relative we know about. That actual sequence from that virus was maintained at the Wuhan Institute of Virology, which has, ever since the original SARS outbreak in 2002, 2003, really been out in the world, and particularly in the bordering southern regions of China, trying to understand where these viruses come from. And so they go out and they collect bat samples, feces, things like that, and also actual blood samples and things from bats, and they take it back to their lab and they study them and try to understand what's out there that could hurt us, right? So that's the closest relative that we know of. Now, what is different between SARS-CoV-2 and this relative? Well, there are 2 particular areas called the receptor binding domain and the polybasic cleavage site. Those are both in the spike protein, which again is the part that binds to the cell. So these are the big changes that gave us something that binds really well to human cells and enables spread from person to person. So let's dive in a little bit more into what those mean. This would be an hour-long talk of itself, so we're going to do the quick version. But basically what we want to say here is if we just look at this outbreak from an epidemiological perspective, okay, there is an outbreak of something that we think came from animals to humans in China at this time of year. Our first question is what we call descriptive epidemiology. What is the who, what, when, where of this? And there's nothing surprising. We've seen it before at this time, at this location, by this mechanism. We don't really think there's anything unusual. Our next question is understand why and how did this happen? And that's where we started to run into problems with this outbreak. First of all, we learned that the original cluster of human cases, which was linked back to a wet market in Wuhan, turned out to not be the first cases. It turns out that there were earlier cases in December. And we also learned that the wet market where that first cluster of cases happened did not have positive environmental samples or positive animal samples coming from them. So now we need to look back further at where did these earlier human cases get exposed and how was the virus already so well adapted to transmit between humans and humans? And there are sort of 3 theories about how that could happen. The first is that there was an earlier version of this virus already spreading from human to humans, and it was slowly acquiring mutations over time that enabled it to spread better and better. And then when it got the right number of mutations and it was really able to transmit well between people, boom, that's when the pandemic took off. That's the first theory. The second theory is something very similar, but instead of it going in humans, it happened probably from a bat into an intermediate species, or possibly just in a bat on its own. where these mutations were accumulating over time that enabled it to spread. Well, if it would ever come in contact with a human host and then, oops, it did, and we're in trouble. And that contact maybe happened when someone was transporting wildlife to a market, or happened when someone was shopping in a market, things like that, things we don't really understand where that happened in the timeline. And then the third is, could these adaptations have happened in the lab? So let's look very quickly at the two adaptations and try to understand what the likelihood is of each of these happening. So these are the two images. I'll go from top to bottom. The first image, what I want to try to explain is the difference between the bat RATG13 virus and SARS-CoV-2. So on this top graphic, you have to imagine an invisible line that goes across the top of the 100% vertical. Okay, so there's a line up top here that says this is SARS-CoV-2. And then there's this blue line. This is the bat RATG13. It's really close. Whereas all the other similar closest relatives of SARS-CoV-2 are very, very further down, right? But this blue line is really close, except in this one area. And that one area happens to map into the spike protein and specifically at the receptor binding domain. So what is the most likely way in nature that that difference could happen? The most likely way in nature that that difference happens, and we see it regularly, this isn't like some crazy thought, is a single cell gets infected with two different viruses. One, say the bat RATG13, and one that's very different, but has a spike protein receptor binding domain that looks a lot more like the one for SARS-CoV-2. And as the bat RATG13-like virus is being copied, the copier is going along to copy, and here's this other strain that looks really similar, and it sort of goes over to this one and it starts copying this one for a minute. And the only way it can do that is if the regions on the two viruses look alike. So it starts copying this one because it looks just like the S protein part I was copying over here, and it copies that one for a minute, and then it switches back and it keeps copying its own. And that's how we get sort of a natural recombination event that is what we call homologous. In other words, it fits, right? It's not something complete. We will also see copies that don't fit, but those don't sustain life, and so the virus doesn't survive. But that's a natural recombinant event. We see all the time, and the most likely natural explanation for seeing this change is by that mechanism. Now let's look at the second difference. The second difference is the polybasic cleavage site, also known as a furin cleavage site. You don't need to know what that means. All you need to do is be able to look at the picture. And the picture will show on the top row SARS-CoV-2, and every row beneath it, everything else that's close to SARS-CoV-2. And what you'll see is there's a spot after 680 and leading into 690. And now these, again, are amino acid positions. So part of the protein chain that's making the S protein, where SARS-CoV-2 has a bunch of additional blocks for additional amino acids that the others don't have. And what those 4 blocks do is it enables the spike protein to be cleaved better so that it can bind better to the in this case, human receptor cell. And so that change in nature does happen. It happens with similar coronaviruses that actually spread from human to human every year as part of our seasonal common cold. And actually 4 different types of coronaviruses make up about 25% of the annual common cold. So you would typically see that in nature as a virus is already in humans going from person to person and adapting to spread better. So that is the most likely mechanism of that happening naturally. But so now we have these 2 changes and we have sort of 2 natural explanations, and we're trying to map that into where did this virus come from? And the easiest way to find that out is to go look for the change, right? So go look at environmental samples, go look at animal samples, go look at banked human samples, and then really look at lab samples and look at the research that was being done to explore those lab samples and try to understand. And why is this important? It is not important to attribute blame. This is important so that this doesn't happen again, and so that we make sure that we interrupt any potential further chain of transmission that could propagate this outbreak. All right, I'm already at 9:40. So what I want to do is
why don't we give you 5 more minutes?
Okay,
I think it's fascinating.
Okay, I'll keep going.
Yeah.
I apologize for being a little long-winded. We'll talk. I'll do a minute per slide for the next 3, and then we'll pause for questions. But so let's just briefly talk about the frozen food hypothesis. So frozen food hypothesis, what we know is that you can recover virus from the surfaces of frozen packaging. What we don't know is whether those can cause infections, and what we really don't know is whether those can spark a pandemic. One analyst who I respect very much likened it to winning a lottery upon a lottery. So the investigation team will be releasing a report in the next few days, hopefully, and it will be really interesting to see what data they have to potentially support this hypothesis and why they sort of gave it more credibility than the rest of the scientific community really did, myself included. And I can think of a few mechanisms of why that might matter, but or why this might be a reasonable hypothesis, but I don't want to guess. So I just want you to know that yes, you can recover virus from packaging, frozen packaging specifically, because it survives well and cold, but no, it doesn't necessarily cause infections. It's been hypothesized to cause infections, but not demonstrated. So how are we going to keep this all from happening again? And what's sort of the major takeaway here? The major takeaway is that there are hundreds of thousands of viruses like SARS-CoV-2 out in nature. And those viruses typically exist in an animal reservoir. They will come into contact with humans by 2 mechanisms. We will go in or they will come out, okay? Us going in is our population increases, our industry expands, we knock down rainforests, we dig our way into these formerly uninhabited areas, and we come into contact, okay? That's one risk. The second risk is we hunt or we eat or we pull out for research animals, samples, and viruses from this community with the potential for exposure. That is something we have to address on the international stage moving forward. And in particular, the second one. I take this pandemic very personally because I've been involved in this for 20 years. And I consider it a personal failure that this happened because we knew, and we've seen over and over and over again, that there are certain transmission pathways mainly involved with pulling animals out and selling them in a certain way in markets for food or other commodities, where we see these outbreaks happen. And at an international level, we haven't had, the drive to really fix that problem. And at this point, it drives me crazy because I'm watching my kids not be able to be kids. That is something we have to address. The other thing we really have to address, whether or not there is any link to a laboratory, and if that link to a laboratory happens to be in China, that is no way an implication on China. It is an implication on laboratory science as it is today. It could just as easily have happened in America. But the fact of the matter is, we are not just collecting samples to understand what's out there. We are then doing experiments with them that potentially enable them to spread better. And these are not weapons experiments. These are experiments that are designed to try to help us understand which ones are important, which ones do we need to focus on, which ones can transmit or could adapt to transmit among humans. And if they did, it would be highly lethal. My response to people that say those experiments are important would be, how much better off were we this time? You've been doing that for 10 years. You've been doing that with viruses very similar to SARS-CoV-2. We were no better off. So not worth the risk, in Rich Pilch's opinion. Okay, but then also there are a lot of things we can learn about the response, and really a lot of it comes down to having a centralized authority and a centralized approach as a global community, and that this is a mutual risk. It is not something any individual country can survive on its own. I'm not going to go into this because we don't have time, but let's just talk for 30 seconds on what this all means from a biodefense perspective. When we do a threat analysis for actual deliberate use of biological agents, we typically look at 3 parameters: vulnerabilities, capabilities, and intent. And arguably, COVID-19 has shifted dramatically all 3 of those parameters. It has demonstrated substantial vulnerabilities. It has potentially enhanced capabilities. And it has certainly drawn interest, documented interest, in using both COVID-19 and other biological agents potentially as weapons. So we are facing sort of a new threat horizon that we have to be ready to deal with. There is also a very important threat to consider, and that's that weapons don't exist in stovepipes. In a nuclear world, there are still biological agents, right? And so as we see outbreaks like this, and we are unable to attribute them, in other words, understand whether they came from nature, a laboratory, or potentially deliberately, some countries who have nuclear weapons reserve the right to respond to a biological weapons attack with a nuclear attack. So this is a problem, and we need to revisit those doctrines and make sure that there is an understanding that biological events that are natural could actually be used to manipulate that nuclear doctrine. My closing statement will just be, we need to work on the international level on 2 fronts. One is improving the WHO's international health regulations, which is our public health response to crises like that. And that's a day-long discussion. The second is we really do need to shore up these laboratory science, safety, and security gaps. And the way I would describe it is, I think we need to start thinking about laboratories more like nuclear reactors. Nuclear reactors are really important. They are probably the key to the survival of humanity, but they are inherent risks, not just to the country that is putting them in place, but to all the other countries around them. And that is the same as a laboratory. And a laboratory, these days, we are just seeing a massive increase in the number of laboratories with less trained scientists doing less perfect practices on more dangerous things. And it is a ticking time bomb. So I do think at an international level, we need to address that. I'll stop there. I apologize for running long. I'm happy to take as many questions as we can.
Thank you, Richard. Fascinating and very interesting. I'm sure many questions are already popping up, and we also received some in advance of your talk. Many of them are really linked to like what we experience now in terms of the vaccines availability and things related to potentially people getting passport as vaccination passports and that prospects. But before I allow you to kind of address that, if we have time, I wanted to combine a couple of questions that came in that actually are all focused on the information, and particularly incorrect information about all these fakes and conspiracy theories and everything else surrounding the COVID pandemic and how we deal with both public and governments and everything else in between. And kind of 2 sides on it. One is, how do you, now that we're having the vaccines rolled out, how do we deal with people still being skeptical about some of these vaccines and other measures? And second is, how do we deal with some of the misinformation out there, and what governments can do in terms of kind of debunking some of this information that is out there. So let us start with that.
Great. No, this is a very important topic. So from a general strategy perspective, I would refer viewers to 2 resources. So the first is UNICRI, so the UN Institute for Crime and Justice Research, is that right? Unicry, you'll find it. And they are working right now to develop a strategy for how to actually handle this. It has 3 pillars. The first pillar is monitoring. The second is basically doing an analysis and actually prosecuting. And the third is debunking. So those are really sort of the 3 critical steps. Is first, we have such an information flow that we need to be able to identify where this misinformation comes from first. Then we need to hold those people accountable, and then we need to actually counter the misinformation. And it's very, very complicated because from a government perspective, at least in America, there's freedom of expression. There's no longer any sort of fairness rule as far as even news reporting. So it really falls on the companies themselves to have to do this sort of monitoring. And what Unicry is trying to do is work with nations and their constituent companies to take that effort on. The second resource is WHO. They've got a whole group called the Infodemic Group that is looking at this problem. They have a research agenda. It's worth looking at what the research agenda is just to see where your organization might contribute. And those are sort of 2 key fronts. There is also a journal called the Health Security Journal, which just this month is publishing on this topic. They've been collecting articles for a while now. So I would recommend reviewing that. As far as practical steps, it's really challenging. The lesson that I go back to is there's something called a backfire effect with information, where sometimes true information countering false information actually works to reinforce false information. So a lot of times where we see actual success is through action and not information. And the classic example I like to refer to is when President Obama received a vaccination in front of people in Africa, right? To try to show that this is okay. In engaging cultural leaders, engaging people who are trusted by the global community is one mechanism. But it's not the answer. And I think the answer lies somewhere with engendering our community and protect our global community, and particularly our youth, with a resilience to disinformation. And that is by teaching the ability to self-educate, to cross-reference sources, to cross-reference information, and make educated decisions about what's accurate. There have been a bunch of ideas proposed for how to make this happen, and they largely resemble ideas from the past, like, for example, the YMCA or the Boys and Girls Club, but translated to the information age. And how can we get these important skills and behavioral traits into our youth now to protect them against this very, very real threat going forward? Unfortunately, these aren't great answers, but that's what I have.
Okay, thank you. Then going back to the vaccinations, and one thing that is certainly on many people's mind is the way they're rolled out, and particularly in inequity and inequality in this, in terms of between, say, the North and the South, and even within the countries, how it is being done. Particularly for the countries that are have less options, fewer options for accessing and to receiving it, and is somewhat a follow-on question to it about the vaccination passports. It's like I'm sure it's on many people's mind is like, okay, in some countries, people are vaccinated and faster, and you would resume your activities. And it seems like this is the idea that is being very actively discussed in the countries. What are your views on these kind of certificate vaccination passports? But first, please, kind of on the disparity between the countries in terms of access to vaccine.
Right. So I think the key with the vaccine is the concept of triage. And that concept is, if I'm an emergency doctor and I walk into the waiting room, I take care of the person who's bleeding out of his head first, and not the person that is there with a cold. So the triage approach is we have to protect the healthcare workers first that are responsible for managing this and are at the most risk of exposure, and then the most severely ill people. And that is the approach we're taking. We don't have a lot of vaccine right now, and countries that have invested in their vaccines are, I think, understandably vaccinating those populations first within their own countries, particularly, for example, in the EU and Europe, where we have the most cases. So even if you're only looking at a triage perspective, we have a real problem right now. There are other countries that don't have as big of a problem. But that should be the approach globally for all the vaccines. There are different types of vaccines, and I think the ones that are more stable are the ones that will be easier to get to people. And there are exercises that countries are doing underneath the COVAX program to help practice that rollout. I can tell you in America, on the number of many mistakes we've made in America, our vaccine rollout has been very, very poor. And we don't have a good mechanism for it. We've had lots of deep cold vaccine expire without ever being administered. We don't have a good registration approach for getting the people who need the vaccine vaccinated first, sort of this massive free-for-all that is crashing web systems. So we are not a good example here. But I think the message is that COVAX has vaccines. It is going to be distributing them. It is also supporting countries with doing exercises for that rollout. And then countries are really, they're going to have to take the vaccine and their rollout plan, which they officially submit to COVAX before they receive the vaccine, and use those to equitably distribute the vaccine. So going to the second question. A question I get a lot is when is this pandemic going to end? And I think, first of all, the definition of pandemic is large population across multiple countries. So if you use that definition, not anytime soon, earliest over a year from now. Where we'll start to see is certain countries and certain areas coming back closer to normal, hopefully by, say, next fall. And hey, there are already plenty of countries that are very close to normal. And those are the ones we have to learn from as far as how they are protecting their populations. And they're protecting their populations through non-pharmaceutical interventions and good screening at borders and ports. I mean, that's really what it comes down to. So when we talk about what is the intermediate future, I think, is drawing from those lessons. And we are going to be realistically looking at some sort of clean zone type approach where every country is going to make a determination on who is safe to come in and out of the country and what countries, other countries, are safe for their people to go into and out of without a problem. And it's a self-serving strategy, but I think it's one that a lot of countries are likely to adopt moving forward.
Okay, switching gears, so we'll have to we'll look at the number of questions related to the to bioterrorism, and you brought this issue and towards the end of your presentation. Let me kind of pose one of the questions that came earlier is, if COVID-19 was a bioterrorism attack, how would the response have been different first? And then are there any studies that you know of or investigations that look at the COVID-19 as potentially as a form of bioterrorism? You already kind of addressed it, but maybe restate in a different way. And then linked to that question, I would like to, somebody asked whether you see a role for the VWC, Biological Weapons Convention, in that framework, that S3 framework, science, safety, and security framework that you brought at the end of your presentation.
Great question. So let's talk bioterrorism first. So in practice, if this were a bioterrorism event, it might look a lot like this. And that's the concern, right? So there are various ways you can detect a bioterrorist attack early, but most people think the most likely way you're going to detect a bioterrorist attack is people are going to start getting sick, and you're going to do traditional epidemiological investigation, and you're going to determine there's a common source of exposure, and then you're going to launch on an investigation of that ultimately leads back to bioterrorism. And that's the concern. The concern is that COVID-19 has exposed these vulnerabilities that may make people, consider bioterrorism as an asymmetrical attack. So that's terrorism, right? Terrorism is different from a state-level biological weapons attack. So the Biological Weapons Convention is an international obligation on state parties to not pursue biological weapons, in a nutshell. And there's a mechanism under the Biological Weapons Convention for a state, any nation, we call them state parties, to raise a concern to the convention saying, we're worried there might have been a biological weapons attack. And then there's a mechanism within the Biological Weapons Convention called the UN Secretary General's mechanism, where that request can then be investigated. And so at a state level, if we were concerned about a biological weapons event here, potentially under the Biological Weapons Convention, under the UN Secretary General's mechanism, in collaboration with WHO and OIE, there would be a more law enforcement focused investigation with more focus on chain of custody and things that go along with law enforcement investigations to try to forensically go back and understand whether this was an actual biological weapons event. But terrorist groups are not under that, so it's different. But those are sort of the two main distinctions. As far as what studies have been done on whether COVID-19 will really impact the future outlook of bioterrorism, I think that the closest thing I could point you to is back again at UNICRI. And what they've done is really just focused on social media posts and discussions among extremist groups about how COVID-19 itself might be used as a weapon. And the idea is, if there are 3 steps to getting a biological weapons, this is very simplified, where you have to acquire a biological agent, you have to produce it, and you have to deliver it. COVID-19 solves all 3 of those. So it overcomes the 3 technical hurdles that you have to making a biological weapon. You already have it if one of your members is infected. You're already producing it because it's making more copies of itself inside that person. And you have a delivery mechanism because that person can now go spread it to other people. So the social media chatter is, if you're a part of my group and you're infected, go walk into that group that I don't like. And the UNICRI report is very interesting as far as documentation of people really talking about that.
Thank you, Rich. I know we're a little bit past the time we allowed for the webinar, but I will allow us to indulge for an additional 5 minutes or so. I think there are important questions that need to be answered, and I apologize to the audience. Those of you who have to leave, you will see, you can always go back to the recording on YouTube that we will post later. But addressing these preventative kind of measures, and you had on your slide these 3 S's: science, safety, and security. But how, maybe you could say a little bit more, how would you imagine an international regime for prevention of future kind of outbreaks, both natural or deliberate, and where do you see the next steps, basically?
So I would look at the next steps on 2 sides. I would look at them first on improving the WHO's international health regulations. And what do I mean by improving? So there were things that went really well with COVID-19 and things that went really poorly, right? The thing that went really well was that China shared the sequence of SARS-CoV-2 early. And that enabled us to start developing diagnostics and vaccines that ultimately are going to be what gets us through this, right? So we want to capitalize on what went well, okay? And then that's the easy one. So what didn't go well? Well, where do we start, right? I mean, I think the biggest takeaway, and I like to think of it as far as, okay, I'm looking at the United States because that's where I am, and what were our problems, and what of those translate to the global stage, right? So in the US, my opinion of the biggest problem was we didn't have a centralized crisis management authority. We had conflicting signals, and we didn't have leadership, and we had responsibility being pushed out on our states. Now, translate that to the international level, and the WHO is there and is doing what it can do, what it has the authority to do, but it doesn't have the authority to really take control and say, I'm in charge, and marshal all of these different countries. It says, here's my advice on this, here's my advice on that, we'll help you with this if we can, and it leaves countries to their own. And I really think as a global community facing mutual risks, we need to sorry. We will need to figure out a way to give the WHO the authority to operate in a more directive way as opposed to an advisory way. I think there are another couple of things we need to learn to do better. One is declaring an emergency faster, which is a sort of a long time complaint about the WHO. They're very cautious about declaring an emergency. And also the idea of restraining international travel. It can't be overemphasized how much interconnectivity has contributed to this event. And it's why we see countries like the US and Europe and countries in Europe that people thought had this great public health system just collapse under all of this, because we had too many entry points for the virus, and we weren't able to wrap them up and get out ahead of them ever. That a lot of that's on us, right? We should have been able to, but at the same time, having a better approach to halting interconnectivity, I think, is important on the international level. So that's we don't need something new for that. We just need to make better what we already have. Okay, but then there's this other problem, and that's a problem that's a gap problem. And a gap problem is we don't have any standard, and we don't have any standard for determining what type of research is performed in laboratories around the world. We don't have any standard for determining what safety requirements are in place around the world. There are WHO recommendations, they are not binding. We don't have any registration system for laboratories performing this dangerous research. We don't have any sort of incident reporting system. And then from a securities perspective, we don't have any requirement for how safe this person needs to be who's going into the lab. What are the risks that person may pose to the community around him? So I think these are major gaps that we've all known have been there for a long time. And regardless of whether there's a laboratory link to COVID or not, I think now's the time. We're playing with fire.
Very interesting. Yeah, so I see a lot of similarities in terms of how the nuclear security field was developing. Is like, and still to this day, we're struggling with like, who's in charge? Is that the member states do it themselves? You can provide recommendations and guidance, but in the end of the day, what are the mechanisms how you can enforce it, or at least compare different countries and apples and oranges in this respect? So we'll have to grapple a lot with that in the bio issues and pandemic. Boy, there are plenty other questions that I would love to continue our discussion. Maybe one last question that I thought that here in Europe, actually, given the deficit of the vaccines, it's rolled out much slower than originally was planned. And there are a number of cases that even health workers are saying that like AstraZeneca vaccine has not demonstrated that same kind of 90% effectiveness as others. And both, in some countries, there is a real pushback in terms of willingness to use it as a vaccine. What could you say to those who are pushing back on AstraZeneca vaccine?
Well, I would say to people pushing back on any vaccine that, well, I understand, right? And we're all concerned about our own safety, but it has to be a situation where we look beyond ourselves. And even if I, Rich Pilch, don't like a vaccine, and I don't like needles, and I don't want to get stabbed, right now, getting a needle is to protect my family, my community, and all of my colleagues around the world. And so it is really important for everyone to be vaccinated. And the AstraZeneca vaccine is very effective at preventing or really reducing severe illness and death. What is not as effective as is preventing minor symptoms. Okay, so I will take minor symptoms to protect the people I love and the people around me. And I hope other people will make that decision too.
Okay, thank you, Rich. I really appreciate that message. And I think indeed I would encourage everyone, as long as you have an opportunity, go get a vaccine, whichever is available and approved in your country. But thank you again, both fascinating discussion about the COVID itself, its origin, and where we are with that, but also starting the conversation about the future of dealing with pandemics and potential linkages with bioterrorism, and both institutional, policy-wise recommendation on where we could go next. I'm sure that conversation and discussion will continue as we're still grappling with the virus. And thank you again, and we'll look forward to hearing from you and other scientists in the field to give us better guidance. But with that, I would like to thank you and all the participants who joined us today, and VCDNP staff supporting the event. And stay safe and healthy, everyone. Thank you. Bye-bye.